Welcome to In the Moment from the DC Public Library, where storytellers become truth tellers, performers become trailblazers, and conversation cuts straight to the heart of what matters. This is In the Moment.
What does it mean to be a grown woman when it comes to healthcare specifically?
You know, to be a grown woman in the healthcare environment really means that it is not someone else's responsibility to take care of you. And I think when you're a girl, when you're a child, it's your mother's responsibility. And for many of us, even as adults, we sort of came into this this relationship with our doctors thinking that our doctors were going to take care of us. But I'm here to tell you that that is no longer really the dynamic in doctors and patients. You are now responsible for taking care of yourself and for managing your own health care. And that is where you really cross that line when you say, okay, it's not anyone else's responsibility, it is mine, and I now have to approach this as a grown woman.
I feel like that sounds very daunting, but it can also be really empowering.
It should be very empowering because I think that we all want to have agency and to be able to take care and advocate for ourselves. The problem is many of us don't know how. And the reason that I wrote the book, and I spend a lot of my time not just taking care of patients in the office, but I am often the navigator and the source for my friend group, for my family, for friends of friends, because it became abundantly clear to me that whatever's going on in the doctor's office, there's a lot of stuff even in that conversation that either doesn't get said or certainly not understood. And I think when we approach this relationship as being a patient and a doctor, there is sort of an inherent power imbalance in that relationship. And what I'm here to tell you is that that's got to stop. And when you become a grown woman, then you deserve to have a conversation with your healthcare provider, be it a doctor, be it a nurse practitioner, but you should be talking at least, not that you're at the same educational level or knowledge level, but you should be able to be spoken to with the same respect, and you should be able to be seen and to be heard the way you would in any other aspect of your life.
I think something that's so interesting is that as women, I think we often care for others at the expense of caring for ourselves. And this book really serves as a roadmap to say, okay, this is a way that you can put yourself first, that you can care for yourself. Was there a particular instance that inspired it, or was it a number of different things? What inspired you to write this book?
Well, I have to tell you, I am, first off, to give you an idea of who I am and what my life story is, I am the youngest of 8 kids. I'm born in Mobile, Alabama, and I'm the youngest by a lot. My oldest brother is 23 years older than me, so I have a brother who's 88. So to give you an idea of our experience with healthcare, it starts with my parents. My mother was born in 1914, so let's do this math. My dad was born in 1893. They were both born in rural Alabama into a situation, these are, you know, black people on a farm in Alabama. They had no real relationship with a doctor because there was really no doctor to have a relationship with. And their view of interacting with any sort of doctor was always under a circumstance where it was something very dire. You know, you didn't just go to the doctor just to be going to the doctor. It was expensive, it was hard. My goodness, they had horse and buggies you had to get in those days. And nothing about that relationship with a doctor for black people in rural Alabama was ever anything that they ever wanted to repeat. It was usually associated with trauma. At the end of this interaction, it usually meant somebody died. So when they had their children, and we finally, my parents moved to the big city of Mobile, Alabama, they didn't have that experience. Nothing about interacting with the doctor was pleasant. I'm most certain that they never felt respected or cared for. And so we weren't raised to interact with doctors in a positive fashion because we never went. My mother would laugh. She was like, why on earth would you go to the doctor if you're not sick? Prevention wasn't a thing. So as we grew up, I learned to respect that ancestral knowledge, the knowledge that was passed down from generation to generation, because my mother knew how to treat a lot of things. And it might have been home remedies, it might have been, something that her aunties or her mother showed her, but she was able to raise 8 kids successfully. I think I could count on one hand and have fingers left over the number of times I actually went to the doctor. But there are things that common sense can't solve for you. And it is this, there's a point at which you have to realize that we have to interact in a way that is proactive, not reactive when there's something terrible going on. And, I'm forever sort of changed by the experience. I lost my mother when I was 12 years old. And she was only 57. And now, when I became an adult and I realized that my mother died of colon cancer, something that everyone now should expect to survive if you know what the signs and symptoms are, and 2, you have access to health care, and you know what regular screening is. None of those things did my mother know. And that was sort of the lived experience of people of her generation. You interacted too late. Very often, those sort of interacting too late stories were the things that fueled some of the myths that we have that you might have heard even from your grandparents today about, the things where they would say, don't let them cut on you, because she was fine till she had that surgery, and then the air hit it, and that cancer spread, and it's sort of like, well, okay, I can see how, 2 things can be true. She did have her surgery, and she did die shortly thereafter. But I assure you, it wasn't because the air hit it. It was because we wait too late. And that is what sort of fueled this whole book in terms of trying to explain to people, these are the things, as a grown woman, you should know. And there are a lot of them, and there's some of them that are just logistics. How do you even pick a doctor? What's important? How do you assemble a team? What's important, what's not about your health history and about your family history. These are the things that are just the basic framework before we even get into any sort of conditions that actually affect women in midlife. And that's important for all of you because we are living in a time now where medicine has changed. And for people who are in my generation, I think that we feel it most acutely because we knew it when it was another way, and now it's something else. And so we're kind of lost and adrift in this whole thing about trying to figure out how to navigate a system that was never created for you and never really, took into account who you are and how and what these things mean to you. And that's sort of the genesis of the book.
It's really interesting because you tell that story about your family and it feels so familiar to stories I've heard in my family. I lost my grandmother to cancer, and I remember one of her brothers said, oh, it's because you're going to that doctor. You shouldn't be. And, I wonder how you think of the marriage between the lore of the past where there is good and we were able to take care of ourselves in certain ways, but also there's modern medicine and you do need to figure out your blood sugar and your blood pressure and all these different things. How should we reconcile holding those 2 things at once?
Well, one, I think we should recognize the wisdom of elders because it's not nothing. They did get to this point in life and raise you. They weren't just, making stuff up as they went along. So we can acknowledge that, but we can do 2 things at once. we can acknowledge the elders and understand that maybe there's a different way of doing this, because we are the first generation, my generation, I think, of women who think we know more than our mothers. You know, it used to be the other way around. Your mother would tell you, and you're like, oh, no, Mom, don't put the baby on its back. Oh, Mom, don't do this. You know, we've got a whole thing because we sometimes go too far in the other direction. And what I'm saying is that there should be some marriage between common sense, that's important, and being able to judge for yourself. And because, let me say this, not everything is an emergency. And I actually spend some time in a chapter in the book really explaining to you, okay, when do you go to the doctor? We sort of go through, all right, this is how you pick a doctor, this is how you assemble a team, this is what's important about your medical history. But what kinds of things should you be able to manage at home on your own? If every time you got a sniffle or a cough or something hurt and you ran to the doctor, you know, okay, so let me show my age here. You know the little fable about, you know, Chicken Little, you know? You know, if every time you run and you're in there every 15 minutes, then what do you think is gonna happen? Well, chances are you're gonna get treated for something you probably didn't need to have. And the other thing is that you're gonna not learn what kinds of things you can handle on your own. You know, I think that it's important to know what the natural course of things are. So your first impulse shouldn't be, you know, unless it's an emergency, and I do explain what things are that are emergencies, and you do need to go and see someone right away. But sometimes just learning to take a minute, take a pause, try some things, then you learn, okay, well, just because I threw up doesn't mean I need to go to the emergency room. You know, I mean, my mother had a very, very high bar, and that bar was probably too high. You know, your head would have to be hanging off before she'd make you go to the doctor. But there is something that we do learn about how to, again, take care of ourselves, because it's not everybody else's responsibility to take care of you, and that's how you learn. Trial and error, and knowing what works and what doesn't work. And just taking a pause for non-urgent conditions, and I say this, of observing 24 hours, 48 hours, am I better, am I worse? If you're better, then you're like, oh, okay, well, I know, well, when this happens, I should take a Tylenol, or when this happens, I should take kaopectate. Whatever that thing is, and I give you some very practical advice. I try to give advice about when is it appropriate to go urgent care, when is it appropriate to wait for a doctor's office visit, when is it appropriate to go to the emergency room. And I think those are things that are very important. Otherwise, you're going to waste a lot of time, and you're going to waste a lot of money, and oftentimes you're not going to get any better outcome.
I want to talk about some issues that Black women in particular think a lot about. You know, we think a lot about hypertension. We think a lot about breast cancer. We think a lot about the maternal mortality rate, and those things do deserve attention. But what are some things that we should keep an eye out for, be on the lookout for, think about, that maybe flies under the radar?
Well, I think there's a whole chapter in there on what I call female troubles. And that was the thing, that was a word that my mother used to use when somebody would be sick or down or whatever, and she would say, well, you know, what's wrong with their mom? And she'd go, female trouble. And I was like, what is a female trouble? You know, but it's fibroids, you know, it is cramps, it's heavy bleeding, it is all those things that are really associated with women's reproductive tracts that we're embarrassed to talk about. That's why we don't call it, we don't name it, because, you know, we have been taught historically to be ashamed of the very things that make us women. And so I want women to know that we're going to talk about these things. We're not going to wait and close the door and whisper. We're going to talk about them, because I want all of you young women to be able to approach these things and to be able to advocate for yourselves and not feel ashamed or stigmatized or to think things are dirty or shameful. No, no. We deserve our own care. And I think that we also are really butting up against the notion that I've practiced gynecology for over 30 years. And I'm ashamed to say that in all the time of my residency and practicing medicine, that I never really knew the history of gynecology. I knew this. I knew that, you know, as we're doing our residency and you're in med school and you know the story, oh, J. Marion Sims, oh, he is the guy that's responsible for creating the field of gynecology. J. Marion Sims, okay, we have instruments named for him. We have positions in surgery that you say put her in Sims, and we know what that means. I never knew the story of J. Marion Sims and how the field of gynecology came to be. So imagine, before the 1850s, there was no field of gynecology. Women were just, you know.
Which, that's wild in and of itself.
No, there was no field. You know, if you see these old history books, the women would go into the doctors and women would be fully clothed and the doctor would turn his head and put his hand under a dress kind of thing because women were so shameful and so dirty that why pay attention to that, right? Well, J. Marion Sims, for those of you who don't know, and the reason I found out about the whole story of him was most of you know the story of Charlottesville, what happened in Charlottesville and tiki torches and the like. But there were demonstrations about taking down Confederate monuments. And, you know, all this is going on in Charlottesville, and then that's Charlottesville, but then there was something going on in New York City. And in Central Park, there is a statue that is commemorating J. Marion Sims, the father of gynecology, who practiced in Montgomery, Alabama, my home state. And after he left Alabama, and this is in the 1850s, he left Alabama, went to New York, and founded the first hospital for women. And so that's why he is lauded as the father of gynecology. Well, here's the problem. The other part of his story is that these women that he practiced on and created this field of gynecologic surgery, he operated on enslaved women. And his job was to correct some of the birth injuries and trauma that these enslaved women had. They had probably been having children too young. They probably were malnourished. They had difficult deliveries. And remember, there's no such thing as a C-section. So if you got pregnant and you could not deliver that baby vaginally, you would labor until one or both of you died. And when these women finally could deliver these babies, sometimes they would have horrific injuries. And these injuries made them not well suited for more reproduction. And that was the value of black women, enslaved women, was your ability to reproduce and create. So he had this idea of like, I think I can fix that, and so let me operate on these women. Well, the problem is he operated on women without anesthesia, needless to say without consent, because there was no such thing that women could consent. And he did it, he operated on these women in public, in front of other people. I mean, just no shame. I mean, very disrespectful to these women. And this is the man that we lauded and held up as, oh my God, he's the father of gynecology. Well, we need to know the whole story. And that's sort of how, if you think of that's how gynecology started, just understand that there is nothing about the field that I would say up to present day that has been specifically designed for you or for your comfort or for making sure. It is just, you know, that's our history, and we have to at least acknowledge that. And so that is why, you know, as I tell the stories throughout my book. I tell family stories. I tell some, sort of composite patient stories because I want you to understand why we are where we are. Women and women's health generally we've been underserved, we've been under-researched, and when it comes to women of color, then then it's an order of magnitude worse than it is for women generally. So we have to acknowledge that so we can do better.
I just wanted to say thank you for sharing all your insights and perspective. It was very eye-opening, but I kind of started to think about so I'm a student at George Washington University, and I'm taking a university writing class that focuses on like critical race theory in society and just like racism and inequality in general. And we were just talking this week about like how the racism and like paid family leave, and that I guess falls around like also infant mortality rates, like being higher for like different groups of people. And I was kind of wondering what you would have to say about like policy like changes that could be made around like issues with paid family leave or issues with like adequate health care and I guess just like racism and health care in general.
I delivered babies for years, and we get into this mindset of we do it that way because that's the way we do it. No one has thought about it in modern times, I say the last 60 years, as women have entered the workforce. We don't have the luxury. When women used to stay home, all right, so you'd have a baby. What it used to be, you'd stay home, you'd have a baby, your mother was nearby, your aunties were nearby. You had a support system that was built into your convalescence. Well, where are we today? Well, we are now in a situation where most of us who are giving birth we're working women. We do not have the luxury of having, family members and people that will take care of us. I was a resident and then a young doctor. When I had my children, I had 6 weeks off the first time, 4 weeks off the second time, and about 4 weeks off the third time. That's not enough time. And we've been doing that to women for an entire generation. We're not taking into account, well, perhaps that's not a good idea, or that's not enough time for you to heal and get back. Another thing that's a simple policy. All right, so let's talk about maternal mortality. 50% of maternal deaths happen between 7 and 365 days after you have given birth, after. So it's not because your doctor was terrible and they did something to you and it's your doctor's fault while you're in the hospital. It happens when you're home. Now, if you don't know, again, it gets back to one of those public education processes. Women are not dying from different things. We're dying from the same things that we've been dying from forever and ever. Perhaps I told you. Perhaps you need another visit, because we used to tell patients, okay, your baby's good, you look great, see you in 6 weeks. That's too long. What if you don't know that, a good percentage of women who even develop preeclampsia will develop it once they're discharged? And we were getting women out of the hospital so quick. You had 24 hours, it's like, okay, bye, with very little follow-up. And these are things that, like I said, these are just policy things that we have to realize that we can't practice medicine in 2024 like it's 1924. Women's lives have changed. Our demands have changed. We don't have child care. All these things, again, and that's policy. And when it comes to women, to Black and brown women who are that oftentimes are at the bottom of the at the economic scale, then the imperative to get back to work is even stronger. So that's why I said, yes, we have to look at these things, but we have to look at them from a societal point of view and stop ignoring the simple things around it and not blaming, not saying, oh, if you just had a neighborhood birthing center, that would solve the problem. It won't. It won't. I have no problems with midwives. I was delivered by a midwife. But it's just the way we deliver care and follow-up that's problematic, not just, where you give birth.
Hi, how are you? I have a 78-year-old mother that I'm trying to, advocate for herself. And she'll tell me things when she comes back from the doctor, and I'm like, well, Mom, that just doesn't kind of sound logical or make sense. What can I do for her to help her advocate better for herself? I think something like this would be great, for women at a senior center or, things like that. Because I think a lot of us, well, I'm way past this generation, but getting better at advocating ourselves, but it's still dealing with a lot of our elders that are, if a doctor says something, it's got to be true, or you don't question them. How do you get them past, that point?
Well, you know what? Again, in an ideal world, everybody needs a buddy system, particularly if you are sick. Because when you are sick, when you get a tough diagnosis and you come in to talk about whatever it is you're going to talk about, it's like this. You hear 25% of whatever they said. And if you can't be there, if you can't have a buddy with you to sit there and listen and answer questions and ask questions for the person who can't advocate for themselves, then you just say to them, you know what? Ask your mom. If anybody who's got a cell phone can say, my daughter is in Washington, D.C. Do you mind if I put on conference calls so she can hear what you're saying?
In the Moment is brought to you by the DC Public Library with support from the DC Public Library Foundation.